Welcome to The Explainer. Today, we are exploring a seriously brilliant framework that takes what is honestly a notoriously complex medical topic and makes it absolutely unforgettable. We're tackling neuroendocrine tumors, or NETs. Look, if you've ever felt like keeping all these different hormones, symptoms, and syndromes straight is kind of like trying to catch water with your bare hands, you are in the exact right place. We're going to build a mental framework together today that is so solid, these concepts will literally just click into place.
Okay, let's dive right into this. Here is our roadmap for the explainer. First, we'll meet the neuroendocrine tumor. Then, we'll map out location and tumor behavior, break down pancreatic NETs made easy, unpack understanding carcinoid syndrome, and finally, look at diagnosis, treatment, and grading.
All right, Section 1. Meet the neuroendocrine tumor.
So when you're looking at the actual word neuroendocrine, it really helps to just snap it right in half. Neuro plus endocrine. To really visualize this, I want you to think of these cells as a robot chef. The neuro part is the robot. It's literally wired to receive nerve signals from the rest of the body. It takes inputs, right? Then the endocrine part is the chef. It takes those signals, goes back into the kitchen, and cooks up hormones to release into the bloodstream. So when we're talking about these tumors, they are essentially rogue robot chefs that arise from these highly specialized cells. They're receiving signals and just relentlessly pumping out chemical messengers when they really shouldn't be.
Now, to build a lasting mental framework for this, it really helps to anchor everything we talk about to the overarching imagery of a fishing net. Whenever you hear NET, I want you to think neuroendocrine, endocrine, tumor. But more importantly than the acronym, picture an actual literal fishing net in your mind. Why? Because we're going to use this net to catch all the different wild hormones that these tumors produce. Just remember this one simple rule for the rest of the explainer. A net catches hormones.
Section 2. Location and tumor behavior. So, where in the vast ocean of the body do you actually cast your net? Well, use the mnemonic GUT, lung. Imagine your fishing net catching food, which represents the gut, and air, which represents the lungs. When we talk about the gut here, we are casting a really wide net over the small intestine, appendix, rectum, pancreas, and stomach. And when we talk about air, we mean the lungs. Now listen. The absolute highest yield pearl you can take away from this specific slide is that the small intestine is the single most common gastrointestinal site for these tumors to arise. Why does this matter? Well, if a patient walks in with really vague, unexplained symptoms, maybe some weird flushing or unexplainable GI distress, knowing to check the gut and lungs first is going to save you valuable diagnostic time.
Once you actually find them, you'll realize these tumors have two very distinct personalities. We can categorize them as functional or non-functional, but honestly, it's easier to think of them as loud versus quiet. Functional NETs are loud. Remember our robot chef? These are the chaotic kitchens actively producing an absolute excess of hormones, and the patient is going to develop very loud, obvious hormone-related symptoms. On the flip side, non-functional NETs are completely quiet. They produce little to no active hormones at all, so the patient doesn't get those wild chemical symptoms. Instead, the symptoms usually just come from the physical mass of the tumor growing and pressing on surrounding tissues over time.
Moving on to Section 3. Pancreatic NETs made easy.
If you want to totally master the functional pancreatic NETs, you literally only need to remember 4 letters. I, G, G, V. Or, if you want a catchy phrase to just stick in your head, I give good vibes. This acronym is the master key. It's going to unlock the 4 most important functional pancreatic tumors you will ever need to know. Let's break those letters down.
Now, what's really fascinating about this slide is how beautifully logical these first 3 tumors are. The name actually tells you exactly what the robot chef is cooking up. First, I for insulinoma. It pumps out insulin. And what does insulin do? It pushes glucose into the cells, which drives blood sugar down. So your key clinical clue is a patient coming in with hypoglycemia, sweating, a tremor, and confusion. Just remember, insulin IN means sugar down. Next up is the first G for gastrinoma. This is basically a gastric acid factory, overproducing the hormone gastrin. All that excess acid completely destroys the stomach and gut lining, leading to severe, recurrent peptic ulcers and diarrhea. The second G is for glucagonoma. As you'd guess, this produces glucagon. Think glucagon means glucose has gone up. It raises blood sugar, causing hyperglycemia, weight loss, and this very classic, highly specific skin rash called necrolytic migratory erythema.
And that brings us to the final letter, V, for VIPyoma. Technically, this tumor produces vasoactive intestinal peptide. But to remember its actual effect on the patient, just think of VIP as standing for very intense pooping. I know, it's a big graphic, but I promise you won't forget it now. This tumor causes a massive secretory diarrhea. Clinically, this presents as the classic WDHA syndrome. Let's spell it out. W for profuse watery diarrhea, D for the resulting dehydration, H for hypokalemia because you are losing so much potassium in the stool, and A for achlorhydria, which just means a lack of stomach acid. And there you have it, that is the I Give Good Vibes pancreatic framework.
Section 4. Understanding Carcinoid Syndrome.
So, carcinoid syndrome happens when a NET is cooking up massive amounts of serotonin. To spot it in a clinical setting, you really want to rely on the 5 F's of carcinoid. Number 1, flushing of the skin. Number 2, frequent diarrhea. Number 3, fast heartbeat. Number 4, fibrosis of the right-sided heart valves. And number 5, feeling wheezy, which is due to bronchospasm. Basically, if you see a patient with unexplained flushing and frequent diarrhea, your mental alarm bells should immediately be ringing for carcinoid.
But let's pause here for a second and look at a really fascinating anatomical quirk. Why does carcinoid syndrome specifically cause fibrosis on the right side of the heart valves? Why not the left? Just think about the normal anatomy of blood flow for a second. The answer is actually pretty simple. Right receives first. When a gastrointestinal carcinoid tumor metastasizes, and it usually metastasizes to the liver, it dumps massive amounts of active serotonin directly into the venous blood return. Well, that venous blood travels straight into the right side of the heart. So the right heart takes the absolute brunt of these highly reactive hormones, which causes inflammatory damage and eventual fibrosis to the tricuspid and pulmonic valves. But here is the cool part. When that blood pumps out of the right heart and goes into the lungs actually metabolize and inactivate the serotonin. So by the time the blood finally reaches the left side of the heart, the dangerous hormone is gone, and the left valves are completely spared. It's just a perfect example of anatomy dictating pathology. Finally, Section 5, Diagnosis, Treatment, and Grading. Okay, so the crucial point in diagnosis is captured in the mnemonic scan plus serotonin. First, we play detective and look for biomarkers in the blood and urine. Now, the general non-specific marker you're going to see for almost all NETs is chromogranin A. But if you specifically suspect carcinoid syndrome, with all that excess serotonin we just talked about, you look for its breakdown product using a 24-hour urinary 5-HIAA test. Once you actually have chemical proof that something is there, you scan to find the mass. This obviously means traditional CT or MRI, but it's totally amazing how specialized somatostatin receptor imaging, like a DOTA-Tate PET scan, works. It actually lights up the neuroendocrine receptors directly on the tumor itself. It's basically a homing beacon.
And this brilliantly illustrates what happens next. Once diagnosed, treatment generally follows the cut plus OCT strategy. It's a two-pronged approach. CUT stands for surgical resection. If the tumor is localized and resectable, surgery is the preferred treatment and actually offers a potential cure. But what if you can't cut it all out and the patient is still suffering from those terrible hormone symptoms? That's exactly where OCT comes in. Octreotide is a somatostatin analog. I want you to think of it as a master off switch. It binds to the tumor and dramatically reduces the hormone secretion, bringing those wild, loud symptoms like the diarrhea and the flushing back under control. Finally, we have to grade these tumors to understand just how aggressively they are behaving. The World Health Organization uses a grading system based on a proliferation marker called Ki-67. Put simply, it tells us how fast the tumor cells are actually dividing. Think of it simply as a spectrum of speed, from slow to fast. Grade 1 has a low Ki-67. That's the turtle. It's slow-growing, far less aggressive. Grade 2 has an intermediate Ki-67. That's walking. Grade 3 has a high Ki-67. That is running. The higher that Ki-67 percentage gets, the faster the tumor is growing, and the much more aggressive your clinical approach needs to be. All right, let's bring this all together with our 30-second memory story and see how beautifully this builds into one cohesive picture. Imagine you are standing on the shore, casting your neuroendocrine net into the water. First, you catch insulin, and you watch the blood sugar fall. Next, you cast again and catch gastrin, and you feel the stomach acid rise. Then you catch glucagon, and the blood sugar rises right back up. You cast again and catch VIP, causing a total flood of watery diarrhea. And finally, you cast your net one last time and catch serotonin, triggering the flushing and diarrhea of carcinoid syndrome. With literally just that one mental image of a fishing net, you've instantly recalled the pathology of 5 highly complex tumors. And guys, that is the absolute power of structured visual learning. We took the chaotic, loud kitchens of these rogue robot chefs, and we put them into a perfectly organized framework. So I want to leave you with this final thought. Now that you have this highly structured approach for neuroendocrine tumors, what other complex medical concepts might your clinical net catch if you take the time to build the right framework to look for them? Thank you so much for joining this explainer, and I highly encourage you to take these mnemonics and start applying them in your studies and your practice right away.